Welcome to the Modern Patient Experience, a show about how U.S. healthcare is adapting to new patient expectations. I'm James Furbush, Director of Marketing at Access One, a company that empowers revenue cycle teams to help all patients effortlessly pay for care in full or over time. In each episode of this show, I interview executives from hospitals and health systems, physicians and nurse leaders, digital health pioneers, and others to better understand what it means to be truly patient-centric. The goal is to serve up new ideas, frameworks, and tactics that will help your organization give your patients the best clinical, financial, and operational experience. And away we go. Hi, welcome back to another edition of the Modern Patient Experience. I'm your host, James Furbush. My guest this week is Todd Guenzburger, the Chief Health Information Officer at Southern Illinois Healthcare. Todd, welcome to the show.
Hello there. Happy to be here.
Yeah, so Todd, I'm kind of curious. I'd like to start off, you are the Chief Health Information Officer at Southern Illinois. I'm sure you're very busy in that role, but I love to hear how executives like yourself, what do you do to sort of recharge your batteries and keep yourself fresh professionally?
Well, I've never had a dearth of hobbies. So I like to cook. I like to eat what I cook. I like to garden. I like to make art. And that keeps me somewhat grounded. And then I'm a voracious reader of non-work material that keeps me distracted and helps me recharge.
I love it. So for reading actual physical books or...
No, I'm a Kindle reader because I sleep horribly and I'll get in a book. And if it's part of a series, I want to download and keep going.
Nice. So fiction then?
Fiction, nonfiction. It's a whole variety of things. I usually have 3 or 4 books going at one time, depending on my mood. And, I scan the New York Times bestseller lists. And
so what do you got? What do you got going right now?
I just finished a book by an author by the name of T.J. Klune, Klune. He's on the bestseller list, and it's about death and sort of paranormal. And he sort of takes the idea of the guy who buries the souls across the river Styx, and he creates a whole sort of way station where that gatekeeper helps people process and pass over. And it's delightful. It's a guy that runs a tea shop, and he works with a reaper, and it's a delightful read and actually quite meaningful and touching.
Nice. That's great. I used to be a big reader, not so much anymore. I have books sitting on my nightstand. I think I've been slowly making my way through over the course of like 5 years now. So it's a little bit sad for me.
Well, I realize I gave the author, but not the name of the book. I think it's called Behind the Whispering Door or something, Whispering Door.
Nice. So as mentioned, you're the Chief Health Information Officer at Southern Illinois Healthcare. And, I'd love for you just to take a couple seconds, to level set the right context. Can you tell everyone who's listening, give us a little bit about, Southern Illinois, the organization?
Sure. Well, we are a small health system, not for profit. We have 4 hospitals, and we serve the Southern Illinois service area. We have 7 primary counties and another sort of 16 that serve as a referral source. We've got level 2 trauma center, cancer, neurology, brain rehab institutes. We have an inpatient behavioral health unit. We are affiliated with the local Southern Illinois University Family Residency Program. And we're part of the Barnes Jewish Collaborative of other health systems like us. When we need quaternary care, we send them on up to Barnes Jewish in St. Louis. And so we share some common priorities as part of that collaborative.
Is that the collaborative? Is that like an ACO arrangement, or what sort of type of collaborative?
It's a structure that will help support an ACO, and they're in the process of trying to deliver that. But it's mostly a way for the executives to connect around certain issues. There's a telehealth group. There's multiple things. Thankfully, there's no conversation about aligning electronic health records across all those systems. And then they're done that. That's not part of the conversation.
But sounds like maybe you don't want to try to align health records across multiple systems again. Do I detect that in your voice?
Yes. I come from a a large system prior to this where our informatics division managed 3 different Epic builds and a Meditech build with a single optimization workforce, and managing that complexity brought its own interesting challenges and opportunities.
Nice. So yeah, so I mean, I'd love to hear, how do you see sort of the role of CHIO as far as that it impacts and can impact, the patient experience for you? How do you sort of think about what, your role and the teams that you run, and sort of how that sort of makes or breaks the experience that patients have with Southern Illinois healthcare?
I've been here almost a year and a half. They had a similar role. I think they called it the CMIO role back then, but it was never full-time. And it was certainly never part of the C-suite. And so when they decided that we've been in Epic Shop since 2017, that they really wanted to start getting more realized value out of their HIT systems, that a role like a chief health information officer that could address traditional CMIO roles, as well as helping folks think strategically about where we need to be heading in the tech and digital landscape as it supports healthcare, was important. And so I think they hired me with that in mind. And so I and my partner, the chief information officer, are part of the executive team, and we're there helping set strategy and connecting the dots and aligning the tools and the digital strategy that will support the health system's priorities. And of course, every health system is concerned with patient experience, and it's myriad ways that you can improve it. And big part of our focus has been on improving access while also exploring some of the newer, more fun, novel, sexy stuff.
Yeah. So so I'd love to hear about sort of improving the access to, because I think that's still a challenge for, I think, a lot of patients trying to navigate. I mean, even just getting the care they need on time, or scheduling stuff and things like that. So let's start there, and then we'll jump into the sexy stuff afterwards, because that's maybe always more fun to talk about, but maybe less important. But you're in the process right now, I understand it, rolling out open access and direct scheduling for patients. Is that correct?
Yeah, correct. We also have a focus of just getting our enrollment within our patient portal, the MyChart portal on Epic, up and with broader penetration across our patient population. And once you've got that portal, you can then open up and provide that convenience of going online and doing the direct and scheduling. And then open scheduling is when you put it through not your patient portal, but through your system website that allows non-established patient to then search for appointments and establish care. And if you do not have your scheduling matrix standardized, it's sort of a clinic by clinic, service line by service line, redoing that so that you can then open those certain types of appointments up for both those venues. And again, the consumer experience elsewhere in your life seems to come to a screeching halt when it comes to healthcare. So how do you continue to slowly mimic that experience and improve that efficiency and that satisfaction? And I consider these core ways to access care that are driven by the patient as table stakes. You have to have that. So we're moving along with those, and while we're at the same time improving our MyChart portal experience. We're sort of right in the middle of the pack when it comes to sort of Epic clients and our enrollment across our medical group patient population. We had a significant uptake when, like everyone with the COVID, initially we were calling negative results, and we finally said, look, you need to sign up for the portal after you got swabbed, and that's how you'll find out you're negative. You'll get a call if it's positive. And that really helped us jumpstart another sort of campaign to get that enrollment in the MyChart going. And then people tend to stick and use it once they find out how easy it is.
Do you have like a benchmark for where you want to get to in terms of portal adoption?
Yeah. And we've met it this year. We're at 45% of our established patient population, which is sort of well in the pack of Epic customers. Some folks are in the 80s and 90s, first things first. And then there's metrics within how well are they using it? Are they using the scheduling? Are they scheduling telehealth appointments? Are they looking up results? Are they doing the e-check-in? All these things that you woo them in, and then you keep them there, and then you keep expanding that patient experience through the tools that you have. And it should be a win-win for both sides, the patient and the caregivers.
Yeah. Have you had, I'm curious about, so you mentioned about sort of aligning a scheduling matrix in order to the open access. Is that sort of part of that project you're doing right now to sort of, sounds like maybe standardize those things to be able to offer open scheduling across the health system?
Yeah, it's one of the strategic priorities for the medical group leadership. So as they choose which service line they want to bring on, I don't have any aegis or agency over how the medical group operations work, but it's like once they're ready and then we can get it into Epic and get it up in the portal and on our, but it's a partnership.
That's great. Has there been pushback from physicians? I know, like early in the early days of, and again, like when you give your access to your calendar, which feels like your personal schedule, I know there's some issues around there, but have you had to sort of navigate any of those waters with physicians in terms of enabling open access?
Oh yeah. Oh heck yeah. Docs and others are great for suggesting how everyone else should function, but as soon as they have to give a little, and so sometimes I'm called into those conversations, but it's very much, and you try to be sensitive to are there truly unique needs, but if you can standardize your scheduling template, you can build those efficiencies of scale, you can improve the next available or third next available appointments and use those as metrics for patient engagement and satisfaction. And you have a service line isn't playing ball, it's a conversation, and sometimes it's many conversations. So yeah, herding physician cats in Southern Illinois is just as difficult as herding them anywhere else in the country. We all think we know how we should work best. And don't get me wrong, satisfaction as a caregiver, as a health caregiver, is so much tied to agency and control of your day. And so you want to respect that. But at the same time, you need to improve the patient experience. And sometimes it's not patient-centered care when you only take the caregiver's approach to this is what works for me. Well, you're 90 days out for a new patient appointment for an urgent issue. That's unacceptable.
Yeah. Do you have, I'm always curious because I would imagine for your role, you're balancing sort of supporting that technology for physicians. So a lot of it's right, like making sure the EHR is usable and physician friendly and things like that, like the right workflows. But then there's, sort of the things you do for the patient side as well. Do you have a split? Like how much would you say you're spending your time? Is it mostly on the physician side, mostly on the patient side? How does that sort of break down for you in your role?
I've never really compartmentalized it like that, but if I have to, I'd say 50-50 because it's so important to improve provider burnout and satisfaction and joy in medicine. And that's extremely hard with the tools that we have. So got to pay attention to their needs. And, COVID, like everyone else, is only exacerbated the tensions or the challenges that were there pre-COVID. And so anything we can do to make their caregiving experience simpler and easier is going to pay off down the road for patients. But at the same time, it still needs to be approached with a lens that is much more different than it used to be. And that's the patient-centered experience. How's this going to impact patient care? And I think sometimes especially when you start encroaching on people like me's authority in how we deliver care, that you got to remind them, hey, this is about good outcomes and serving the patient. This is why we went into medicine. And come on. I used to joke sometimes the most successful way to be a good CMIO is to be able to look your peer in the face. I wish I could do it and raise the one eyebrow and do this Spock look and say, really? Seriously? Come on. This is not right. You got to make a different decision here. And they'll listen to that from a peer who knows that they understand their side, but also is trying to get them to move to a different place when it comes to particularly the use of the tools.
So should we get into the sexy stuff?
Sure.
What do you sort of, for you and your role? I mean, are you evaluating different solutions? Like what sort of stuff are you looking at as far as things that can improve the patient experience?
Well, we have a whole consumerism work group that leaders across the system are part of, and both the CIO and myself are involved in that. we have a tremendously strong foundations group, and we are constantly applying for grants. And we've done a couple that recently that really focus on the use of technology, improving access to care, improving health outcomes, and improving health equity. And we certainly have a lot of those issues in Southern Illinois. We suffer from the last mile issue. So, for example, when we think of our telehealth strategy, or some of our other digital apps, or our remote patient monitoring, we look at 3G and 4G experiences. So we've got remote patient monitoring going with our CHF populations. We're looking to span that. I brought to SIH the opportunity to use Xealth, Xealth, which is a product that I helped scale when I was at Providence, and it was actually born at Providence in their innovation. And this is a way to marry digital assets and the core electronic health record system. So essentially, you can create a digital activity tab that allows you to prescribe a digital asset like maternity app, or a behavioral health app, or a diabetic education app, or even order an Uber or something off of Amazon. And it keeps that right in the doctor or the caregiver's workflow, rather than having to go to yet another tech tool to sort of engage the patients. And I was really excited about that when I was at Providence. And I think that's a great sort of foundation that allows us to scale more easily other digital assets as we bring them on
And do
board.
you have a process for bringing those digital assets on, like a framework for evaluating and bringing those assets on?
We're getting there. Governance and steering is hugely important. And so we're looking at some of our current digital assets and trying to pull them back in and rearranging things. So, yeah, ultimately, the value of that is it allows you to sort of create a compendium of, this is the tool that we use for diabetic education at SIH, or et cetera. And so the opportunities are legion. There's a huge amount. Of course, demonstrating ROI for these assets, it's difficult. And folks that have been using some of these alternative ways to engage patients and improving patient experience, how to tie that back to real dollars. I think everyone is still fundamentally trying to connect that and say, yeah, this was right. But you can't afford not to go there. Patients expect it. It's a cool way to deliver things. And, payment mechanisms need to shift. And so it's a pea soup, and everything's trying to settle out. And you got to advocate for where you see the world going and saying, yeah, this may not be profitable right now, but it is the right thing to do. And if you wait until it is profitable, you're way behind.
I
So,
mean, and so, it's pretty true because I feel like with some of these digital apps, certain like following care plans at home or managing care, like self-managed care, things like that, a digital app is a really great venue, a really great approach to do that. Like, I feel like for me, if I have like an exercise app on my phone, it's like I'm more likely to follow that program if I don't have to put the thought into managing that myself. And I would think that same mindset would carry over into if I am rehabbing a surgically repaired knee and I'm now at home, but I have to do certain exercises or I have a care plan, things like that. Is that how, I'd be curious, is that how you're looking at some of these digital assets for care
yeah,
journeys and things like
yeah.
that?
Yeah, so we use Emmy for a variety of things on patient education like that. And so the pre-op experience will help set patient expectations, and hopefully that will then improve outcomes. Part of my frustration is an individual PCP who, say, had a patient go through a flu campaign or did go in for surgery. They don't know, when it was not within the core system, whether that patient actually utilized that app, how many times they watched said video, et cetera. The beauty of Xealth is that it brings that back in, and they can have an experience saying, yeah, the patient did pull this up on their phone, or they did pull it up through the patient portal, and they watched that video 3 times. So then the caregiver could say, I see that, you watched that. Did you have any questions? And again, it promotes that patient, doctor, or caregiver experience when they're in front, because you're talking about something that maybe was recommended and following up and ostensibly dealing with issues that matter to the patient.
Yeah, that's awesome. So it's
Well,
almost like figuring out that way to sort of tie in these digital experiences, but ensure that the loop is closed, or it's at least as closed as it possibly can be for both the physicians and the patients.
Yeah. One of the grants that we applied for in terms of trying to address health equity and improve access was we were trying to link technology and our community health worker program and community-based organizations that can work with us to help define the community needs. And then when tech can help that, continue to see how we can link them. So there are two apps out there that aggregate community-based resources, and you can take an electronic referral and to that community asset, and then the community health worker can go out and facilitate, alignment. Say their problems are food insecurity, and you've got a food pantry that happens to be plugged in. You could prescribe food resources, for lack of a better description or term, and try to bring those things in. We considering kiosk and or literally there are quite a few counties. I was shocked to learn, I don't remember the exact number, but I think half of our service area, which is about 20 counties, where there isn't a single OB provider.
Oh, wow.
Yeah. So you think in this day and age how that could happen, and yet that's actually not so uncommon. So could we create, telehealth hubs where a community health worker could go in and facilitate patient care experience where we didn't have a clinic, but we could do that tech outreach and improve access, impact true outcomes that are going to make a difference, address some of those social determinants of health and inequities that are out there. And it's an exciting time.
Yeah. So that's a good point. One of the things that I kind of made a note. So you're talking about sort of the last mile challenges that you have, which often doesn't get talked about enough, that like there are a lot of places in this country that really don't have good internet or reliable phone service pockets. How much of a challenge has that been? Because again, like telehealth, to your point, like it's hard to do a telehealth visit if they're in an area that doesn't have good, reliable cell phone service or broadband internet.
Well, we do have those challenges. I think you have to advocate at the state and national level that, broadband at some point should become a utility. And it's a necessary way, just like electricity, to deliver so many services to people. And then when we can't get that, we try to make sure that we're addressing things with, 4G networks that, most folks still really do have a cell phones. They may not be always have the greatest reception, but they do have them and they can move to a place where they can. But, where it's really difficult, and you could set up a community center and put that telehealth sort of console and support it with the community-based organizations and schedule consultations and schedule patient education. And it's one way to try to bridge that final mile. But
That's awesome.
at this point in my career, it's great to improve the connected experience for the people who are already connected, but I don't want to create and solely focus on how to take the connected and make them even more connected when there are such disparities out there. And so that's why I really enjoy partnering with our foundation work and with our community health program and a lot of outreach. Like everyone, we're struggling with FTE needs to keep our clinics and hospitals staffed. And we started to take a look at, well, what can we do, even starting at the grade school level, promoting a particular path in education and getting those role models out there and partnering with churches to say, if you take the right classes in high school, you can come into a laboratory services job and make a great income, or nursing is a great path. And we've got a nursing school or an RT, all these things. You've got to start earlier and earlier. And so I really like that segment of the population is really where addressing those population needs rather than sort of the specific prescription. I mean, forget who said it, but the zip code where you live shouldn't be a determinant of your health. And unfortunately, in this country, shockingly, that is.
Yeah.
And so instead of providing more and more care to the connected and the financially able, let's figure out how to do more for those who have less.
Well, and
It's the mission of the not-for-profit.
no, that's amazing. And I mean, and so much of care too, right? It's dependent on your zip code. And I mean, so much of it is outside of, so we talked about like having prescriptions for essentially the social determinants of health, right? Like food insecurity and things like that. But actually like so much of that actually has a greater impact in some way on a person's health, where you can't pay for your heat in the winter. Like that's a major health concern and should be.
Yeah. And, granted, I'm not a PCP anymore, but that's not where I want to focus my connectivity.
I can say as someone who
But
tracks the steps, it has not helped me much at all in my health, even if I hit those numbers. So I can feel that. So so Zelf, sounds like a great initiative. The open access and direct scheduling also, fantastic to allow patients have, an easier time navigating the system, getting them on, my chart and the portal. What other initiatives do you have under your purview? Are you thinking about for the rest of this year? Are there things that you're already thinking about as a priority for next year?
yeah, well, this is hardly groundbreaking because a lot of folks have gone there quicker and faster. But as we've faced our access issues with our COVID surge numbers, we've been looking at COVID at home strategies where we can get people who have recovered but still need oxygen out of the hospital quicker so we can free that bed up or discharge them from the ED. And so, what are those remote patient monitoring strategies that we can hook up for more and more indications? So, it's not so much different things, but expanding the scale of what you've already done. And it just takes longer than I would like to get these things active by the time you make sure you're approaching things from a compliant way and you're billing the right way. It's like, unfortunately, this is not going to be ready till the next surge. But, I'm not going to give up because it's going to happen and then it will be in place. So, I think focus is really important. Don't spread yourself too thin and try to scale what you have while also kind of keeping your eye on emerging opportunities.
Yeah. But I'm curious. So for you, do you have an eye on certain emerging opportunities, or what are you at least thinking about as a CHIO and what you may want to do down the road?
Well, we've given thought, but not really committed to hospitalization at home, which was sort of an expanded scope of, the COVID at home. Our most recent hospital is just acquired and they're on a different system. And until we can move them over to our electronic systems, we're looking at how we can do more teleconsults so that they can access our expertise and we can deliver care without having to drive. So some of those internal things that just continue to promote connectivity. And then we'll explore wherever operations tells us to move forward. They're interested in a particular problem. My partner and I will be exploring what's out there and serve them up the opportunities and help them make a decision. So I don't feel like we're particularly innovative compared to a lot of organizations. I don't mind being in the middle of the pack, but you definitely don't want to slip behind. And so some of the stuff that we absolutely need to improve, we're doing those fundamental or foundational things. I know our Marcom folks are also we're interested in putting in a CRM product so we can know more about our population base. The consumer data through those AI engines that can tell you more about your patients and the zip code and what's going on there that might help you select priorities or some of the other things we're starting to look at. How do you know your patient better? You can't provide an improved patient experience until you know who your patients are. And so we're exploring those avenues too.
Yeah, that's awesome. And so do you have places that you go to sort of find ideas and bring ideas to that consumer working group where you're like, hey,
Yeah, you can work with aggregators, I call them, like Avia, for example, that go out and work with health systems on certain problems, and then they'll go find tech for you to go evaluate. We work with a group called Global STL or St. Louis, which is a group that does the same thing that also brings business opportunities into the Midwest and serves up tech and healthcare that we can have innovation fairs. Of course, I do a lot of reading. I keep up with my peers. I recently took a course on leading digital transformation in healthcare from Harvard Business School. And that was fascinating because it was an international classroom. And it was interesting to hear folks' ideas and what they're doing from large and small health systems within the US. But most of the class was actually international. It's open to vendors and just sort of, we're all kind of struggling with the same problems, but in slightly different ways. And we come at it with slightly different venues. And that was a fantastic experience. And, I know I probably differ than a lot of folks, but I approach with a skeptical eye the hype that AI is going to solve everything in this world, and especially in healthcare. So, certainly not developing any of that capacity within our systems, but we're being very careful about where we lean towards an AI solution to improve our operations or improve health outcomes.
I think part of the problem is,
I love your
well,
face.
I mean, part of the problem too with AI is that it's, I mean, just a tool, right? So it's how you kind of
Yeah,
use it, implement it. It's not a magic silver bullet wand that you could just flip the button and like problems go away.
exactly. And it's massively complicated. It's subject to bias. It's, think about how hard it is to incent the right behavior in healthcare. I mean, I don't know a single physician that likes how we measure quality right now. And yet, if you define opportunity through these algorithms and they're based on your assumptions and the way you measure and approach, you could end up with something that you didn't anticipate, and we will. And so I think there's always going to be a hype cycle, and definitely is going to be an important tool in the future, but it's not for everything. And it's certainly not the panacea. And all right, insight. That's really important. But I have so many things that I know I should be doing right now that I don't need an AI engine to be telling me that I could keep busy and it would improve patient outcomes and the patient experience. And we knew them 15 years ago. So it's like big data is helpful. And unless it really creates an easier path from getting from A to C by eliminating B, you still got to do the work. You got to execute on that insight. And an AI engine is not going to do
No,
that.
it's, I think someone once told me that it's always stuck in my brain is that like if you automate a broken process, you still have a broken process.
Yeah.
So I think about that a lot with
Yeah.
respect to automation and AI and things like that, that it's not a panacea.
Yeah. Well, the core competencies still are always going to be important
Yeah.
so that you can capitalize innovation. So much transformation fails not because the idea was good or the tech was bad, but that your core competencies to execute on that transformation were the weak point. And so leadership is hard, accountability is hard, performance management is hard. And those aren't tools, those are people processes.
I want to jump back to this sort of digital transformation class you took at Harvard. I'm curious, do you have like one or two, three takeaways or learnings, like things that stuck with you? Only because it's fascinating that you get in a room with like international, other people from other countries that may, I mean, like healthcare, in the UK is vastly different because they are a single payer system and a lot of countries are. Care in Germany is different. Care in Singapore is different. And so I'm curious, were there any sort of things that stuck with you that you're still thinking about from that?
Sure. Well, we talked about two of them already, and they brought about, execution and transformation and core competencies. Yeah, that was great to hear. Is almost the entire focus of a course as a foundation. That my skepticism and conservative approach to AI was well warranted. So I don't know. It's like going to a continuing medical education conference. I rarely learn anything new. I just validate that I'm not as dumb as I thought I was, and that I'm actually just, yeah, I'm thinking about the right things in the right way, and not any better or any worse. And yeah, I'm working on the right work. So that's the main reason why I took the course, is to say, all right, am I thinking about this from a broad enough perspective, and what's my opinions about this after doing informatics for 15 to 20 years? And it's like, yeah, I'm still on target. These are the same conversations that are happening in this classroom that are happening in my boardroom. So that was reassuring. I used it more as reassuring. They did have a great lecture on bringing some of these change challenges to the third world. And we thought we had problems with the
Sure.
final mile. So, and it was interesting to hear a lot of the vendor folks talk about, well, how do we insert ourselves more into these conversations? How can we be of more value to promote your transformation needs? And I think they were there to mine people's minds like mine about where we were and what we were doing.
Yeah. Nice. Well, that's great. Well, Todd, I have kept you long enough. Thank you for sharing your insights with us. This has been a great conversation. I know I've learned a lot. So, thank you for making the time to kind of walk me through what you're up to at Southern Illinois Healthcare. It sounds like you got a lot going on. So I really appreciate you making the time and sharing your knowledge with us.
Thank you. Appreciated the time.